countries. But it's also designed to promote collaboration between sectors. As COVID-19 demonstrated, a pandemic is not just a health crisis. It affects economies, education, trade, travel, food supply systems, and more. PRED will therefore support countries to engage as many sectors as possible, as well as civil society groups, religious communities, and young people. This integrated approach will help countries to review, test, and update their pandemic planning efforts to ensure they have the right capacities and capabilities in place. The COVID-19 pandemic was a powerful demonstration of the life-saving power of vaccines. This week marks World Immunization Week. Although vaccines have played a key role in helping to curb COVID-19, the pandemic severely disrupted routine immunization programs around the world. Over the course of the pandemic, essential immunization levels fell in more than 100 countries, leading to rising outbreaks of measles, diphtheria, polio, and yellow fever. Between 2019 and 2021, an estimated 67 million children missed out on at least one essential immunization, including 48 million children who missed out entirely. This dramatic reversal follows almost a decade of stalled progress and has set back vaccination rates to levels not seen since 2008. In response, WHO and our partners have launched the Big Catch-Up, a global effort to boost vaccination levels in children to at least pre-pandemic levels. The Big Catch-Up will have a particular focus on 20 countries around the world in which 3/4 of the children who missed out on vaccination in 2021 live. But all countries, rich and poor, have work to do in addressing the barriers to immunization, whether it's access, availability, cost, or disinformation. Finally, yesterday marked World Malaria Day. Incredible progress has been made against malaria over the last 2 decades. Advances in nets, tests, and medicines have helped prevent more than 2 billion cases and save an estimated 12 million lives. The world's first malaria vaccine has so far reached 1.5 million children in Ghana, Kenya, and Malawi, and the second malaria vaccine is now in development. These innovations have been made possible by investment in cutting-edge research and development. But even with all of these advances, malaria remains a leading cause of death for people in low-income countries and still claims more than 600,000 lives each year, disproportionately affecting poor and marginalized populations. At a time when more investment is needed, the global malaria response faces significant shortfalls. World Malaria Day is a reminder of the urgent need to close investment gaps, scale up research and development, and expand access to malaria tools and services for the most at-risk populations. By using all the tools we have, old and new, we can move closer to the vision of zero malaria. Fadila, back to you.
Thank you, Dr. Tedros. Now I will open the floor to journalist questions. If you want to ask a question, please raise your hand using the raise your hand icon and unmute yourself. We will start with Nina Larsen from Agence France Presse. Nina, can you hear me?
Yes, thank you. Can you, sorry, can you hear me?
Very well. Go ahead, please, Nina.
So I just wanted to ask about the lab occupation in Khartoum. I was wondering if you had more information about who was behind it and what happened and the specific risks that you're concerned about, what diseases, and if you're worried they could be released not only to the people in the labs but also into the population. If you could say a little bit more about that. Thank you.
Thank you, Nina. Dr. Ryan?
Yeah, we don't have complete information at this point around the incident. We know that the lab was occupied. It's a national public health lab, and it was doing routine diagnostics and reference work for the public health and clinical services in Sudan. And as such, it was dealing with what we consider normal pathogens for the country. And I'll let Olivia and Abdi detail that. Certainly, this does represent an attack on healthcare. The occupation of a laboratory denies that service to the hospitals, to the doctors, to the patients. And at this time, our primary concern is the health and welfare of the people of Sudan. And right now, the major danger to the health and welfare of the people of Sudan is lack of access to clean water, lack of access to food, the risk of direct injury with guns and tanks and other weapons being used indiscriminately in civilian zones. So when we look at what are the major risks to the civilian population of Sudan, they are the risks. Having said that, having untrained personnel in a laboratory facility is not a good thing. That's why we train laboratories workers. That's why we have different levels of BSL, biologic we have different levels of security of biologic agents, and we want to make sure that we have strong levels of biosafety in all labs, no matter where they are. When lab workers are forced to leave a laboratory and untrained people enter that laboratory, there are always risks. But the risks are primarily to those individuals, first and foremost, to accidentally expose themselves to the pathogen. But there are always obviously secondary risks that someone might leave that laboratory and infect someone else. But right now, the vast majority of people have been infected with infectious diseases in Sudan are doing so because they're having to drink dirty water. They're doing so because they're crowded into basements and unable to access care. They're doing so because vaccination is not happening in young children. So when we look at biologic risks, as you put them, the main biologic risks to the to humans in Sudan is the fact that there's an ongoing conflict, there's ongoing war, and the denial of public health and health services to that population is what represents the major risk to health and the major risk of infectious diseases. Having said that, WHO is following up obviously very closely with the authorities, trying to, number one, establish what the current status is, whether the lab has been is still occupied. And to try and get in as soon as possible with the national lab staff to do an assessment of the security of the disease pathogens that are held there. We have no, and again, before the next question is asked, we've no particular reason to believe that there's any other intention in this. The risk probably remains to those individuals who've gone in there. Many health facilities have been occupied. Many government buildings and other things have been occupied. We want to make sure that the people occupying that building know the risks to themselves. And we will try to continue to communicate those risks. But as I said, the team on the ground and with our biorisk and biosafety teams here are carrying out an extensive risk assessment to the best of our capabilities. But remember here, internet, telephones and other things are down. In Sudan, communications are extremely difficult. Doing any kind of assessment at the moment on health status is very difficult. And again, the reason for that is violence. The reason for that is warring factions, fighting over territory, fighting over control of Khartoum and other cities. And unfortunately, it is the civilians of Sudan that are in the firing line. It is the health system in Sudan that's in the firing line. And the major risk to the health and welfare of the people of Sudan remains a conflict. And we need to keep the focus on that. But as I say, we will not ignore a situation where health facilities, and particularly labs, that whole samples are kept. There's always a biologic risk associated with that act, but we need to put it into context with what's going on in Sudan right now. I don't know if you want to give details on the work going on that level, Olivier.
Yeah, thank you, Dr. Ryan. Olivier Le Paulin, who is the incident manager for Sudan response. Olivier?
Thank you very much. Not a huge amount to add from what Mike said. Of course, we're working with our colleagues in country to understand the situation a bit better. There's a risk assessment that is currently ongoing to assess the potential public health risk of this event, which, as Dr. Ryan highlighted, is an attack on healthcare. The main risk with the lab at the moment is for a national reference lab not to be able to perform its normal public health duties, which puts the population of Sudan at risk, of course, by not being able to detect epidemics if they come up. We are aware of some samples of pathogens that are being stored in the lab: measles, COVID, or SARS-CoV-2, TB, particularly MDR-TB, cholera, and vaccine-derived poliovirus, but the assessment is ongoing to better understand what the public health risk might be with those. And of course, the risk as well of having untrained personnel or untrained individuals in the lab mishandling some of these samples, potentially leading to themselves exposing themselves to those infections is also a risk. But again, the risk assessment is ongoing, and we are following the situation quite closely, and will report as we understand the situation better.
Thank you, Dr. Le Paulin. Now I would like to invite Alexander Teen from CBS News to ask the next question. Alexander?
Hi, thanks for calling on me. On a separate topic, can you discuss the XBB.1.9 sublineage? How does that compare to the mutations, the growth, and the symptoms that we're seeing with XBB.1.1.6? And then separately, given the measles outbreaks in the Western Pacific, do you think travel restrictions are warranted? And why do you think these outbreaks are happening now? Thanks.
Thank you.
Yeah, so thanks for the question. So XBB.1.9 is a sublineage of XBB, which is a recombinant of two BA.2 sublineages. They have very similar characteristics to XBB.1.5. And also XBB.1.1.6. I mention those two specifically because we have two risk assessments that have been published that detail the increase in growth advantage that we've seen for these XBB sublineages, and that would also include XBB.1.9. We do see immune escape, which means people can be reinfected again, despite being previously infected or vaccinated. But we have not seen a change in severity with the XBB sublineages. XBB.1.1.9 currently is around, of the sequences that have been shared with GISAID and that we are able to analyze at a global level, is around 10% of the sequences. And putting that into context, XBB overall is dominant worldwide. So this just indicates to us that the virus continues to evolve, and it will continue to evolve because the virus is circulating pretty much unchecked. And what we need to be able to do is to keep surveillance up, so that we have people who are tested first and foremost to ensure that they get into the clinical care pathway, but also so that we can monitor the virus itself, understand what each of these mutations means, so that our technical advisory group for virus evolution can carry out these risk assessments, and so that our technical advisory group for COVID-19 vaccine composition, this is the tag COVAC, can make updated and informed decisions about vaccine composition. And in fact, they will be meeting very soon to discuss that. Because we have to remain vigilant. As the DG said, the virus is not going anywhere, and we have to learn how to manage this appropriately. So one of the things we need to be able to do is to look at these viruses very carefully and assess them robustly, rapidly, so that we can inform decisions that we provide to you.
Thank you, Dr. von Kerkhove. I would like now to call on Dr. Kate O'Brien, who is our Director, Immunization, Vaccines and Biologicals, to answer the second question about measles in the Pacific. Kate, can you hear me?
Yes, just to follow up on the question, and in the Director General's opening statement, The outbreaks of measles that we're seeing, first of all, are escalating in terms of number and in terms of size. We now categorize about 33 countries as in the past year as having had what we call large and disruptive measles outbreaks. And the reason for these outbreaks is a direct result of people in countries who are not immune to measles. I think you all know that measles is one of the most infectious viruses. So a measles case that occurs will cause somewhere between 12 and 18 additional cases among people who are not immune to measles. And there are really only two ways you become immune to measles. The first is by being vaccinated. And we recommend a 2-dose schedule or having had measles in the past. So the measles outbreaks are happening because of these, what we call immune gaps, large sections or substantial sections of the population that aren't immune to measles. The backsliding in the immunization program as a result of the pandemic over these past 3 years has resulted now in 25 million children in 2021 alone who didn't get vaccinated with measles vaccine. That's the first dose of measles, and an additional 15 million on top of that in 2021 alone that didn't get their second dose of measles vaccine. And so, this is the critical nature of being able to press the accelerator pedal to enhance the immunization program in 2023, to catch up all of those people who didn't receive measles vaccine, to restore the immunization programs and to strengthen them even further so we don't have further left outs moving forward. You asked a question about travel restrictions. Measles is a virus that is found in many countries around the world. What is more important is that when people are traveling, especially if they're traveling to an area where a measles outbreak is going on, that especially for the children, but for all individuals, to know your vaccination status with measles vaccine or your past history with measles for those who were born before measles vaccine was available. So that's the key thing to check before traveling to an area that has a lot of measles going on at the time. Thanks very much.
Thank you, Dr. O'Brien. I would like now to invite Helen Branswell from STAD to ask the next question. Helen, over to you.
Thanks very much, Fadela. I have a couple of questions. One is just a clarification, and then my main question. The clarification is about this PRET initiative that WHO announced this morning. RSV is one of the pathogens that is included in the first unit, apparently. I'm puzzled by that because RSV, is it thought that RSV could cause a pandemic? And then the other question is relates to the Marburg outbreak in Equatorial Guinea. At points, the WHO has indicated that it believes there has been potentially undetected chains of transmission, that some of the cases have not been linked to other cases or links have not been found. Does WHO still fear that is happening? Thank you.
Thank you, Helen. I would like to invite Dr. Abdi to take this question on Marburg. Marburg? Yes. Dr. Abdi on Marburg, and then I will invite Dr. Briand to take the first question. Dr. Abdi.
Thanks, Helen. On the situation in Equatorial Guinea, we are seeing quite a detailed investigation done by our partners and the Minister of Health, and just appreciating our US CDC colleagues for the detailed investigation done under the leadership of the government. As we said previously, and the government has been sharing updates on Twitter, we had the last case onset reported on 20th April. So I just wanted to clarify here some point that caused some confusion, maybe senior officials or some even the media. When we talk about countdown, is the last exposure, potential exposure. So as we speak right now, we have one patient still admitted, and that WHO has 3 criteria. When we start that 42 countdown is after that, when we have 2 negative tests for that. So as we have seen And this want to take this opportunity to Tanzania, which just started the countdown yesterday on 21st April after 2 PCR. So these two outbreaks that are happening concurrently are having different evolutions, 10 weeks in Equatorial Guinea and around 5 weeks Tanzania. But lessons we have learned that virus can always surprise us again and again. So in terms of the AP, what we are seeing the trends are these clusters that are interlinked. One of them we didn't know where it was that, and eventually it's part of the existing cluster. So we are seeing interlinked clusters spread across geographically, whether it be in Mongoma or Pata, but we haven't seen a widespread community transmission. Having said that, the risk is still there, 10 weeks on it. This may be the second largest MVD outbreak that we are dealing with, not only for Equatorial Guinea, but also to the neighboring country. So we just would like to take this opportunity to appreciate the leadership of the Ministry of Health, all the government apparatus to safely contain this outbreak so that we don't see a spillover to the neighboring country.
Could just supplement there. I think Abdi has said it all, but I think it's important. I think many people perceive that hemorrhagic fevers outbreaks because of our West Africa experience or the Congo experience are just explosive outbreaks that just, but very often with hemorrhagic fevers, they start with long chain transmission and they can continue in long chains that don't look particularly dangerous. It's just one case and then another case and maybe two cases and back to one case, but they're all linked. And in many ways, once that virus is transmitting and being able to sustain itself there and you're not able to detect all those chains or you're not finding those cases, the danger is that that virus finds its way into a large funeral setting or that virus finds its way into an unprotected healthcare system. And we saw that previously in Angola and Wish. Single case going into a hospital, a very, very unsafe practice of injection, and we had literally tens of cases within a couple of days. So this is not to say that we've got a massive event continuing in Equatorial Guinea, but we're going to need to have sustained, targeted surveillance going forward for a number of weeks. We're going to need to maintain vigilance and also make sure that the population are on the alert, that people are incentivized to report this disease, not disincentivized, and that we see that continued sensitivity to the fact that patients presenting with unusual symptoms, presenting with bleeding symptoms to any healthcare facility need to be carefully investigated. I believe it's a reasonably straightforward job to shut this down, but I think what WHO would like to see is continued vigilance, continued surveillance, continued open, transparent engagement with communities, and I believe this epidemic will end. But as we've seen in the past, one unusual event, one unfortunate amplification, and we could be in trouble. So I think this is the concern we have. So we're not saying by any means that there's a massive undetected problem out there amongst the population in Equatorial Guinea. I don't think that's the case at all. But while the hemorrhagic fever is spreading or moving in a human population, we need to be extremely cautious and vigilant at all times.
Thank you, Dr. Ryan. Dr. Sylvie Briand will take the first question.
Yeah. Thank you very much, Fadela and Ellen. So PRET is really an initiative to strengthen preparedness against epidemics and pandemics of emerging threats. And so, of course, we don't know what kind of threats will emerge in the future, and that's why we need to have an approach that is very broad and make sure that we build resilient systems and capacities to be able to tackle different types of threats. And so that's why we have convened this meeting and worked with a very large group of people to start this process by addressing a group of pathogens called respiratory pathogens. So it includes, of course, COVID-19, but also any kind of other coronaviruses, and also influenza and RSV is part of them. Regarding the specific work we have been doing to start with this initiative is really first to learn the lessons from COVID. because we have learned a lot during the past 3 years, and we don't want to lose this experience. Second is to maintain also the capacities that were built during COVID, because these capacities have grown in many countries, especially low and middle income countries, and we don't want to lose these capacities. And third is really to integrate the innovation that we have seen during COVID, for instance, genomic sequencing and so other capacities in labs or in surveillance or in vaccine, etc. So this initiative is really important to prepare the world for future threats. You have asked specifically on RSV. So I think, again, the issue of RSV is that it's part of this group of respiratory pathogens. And the advantage of RSV is that, like flu, it is producing seasonal epidemic or epidemics that are recurring epidemics. And so using RSV or seasonal flu is a very good exercise, I would say, to make sure that the systems we have in place not only are resilient to any kind of crisis, and regardless of the size, but also that we can regularly use those systems in place to face a crisis and have this capacity to scale them up and down regularly, so that we make sure that in case of a major problem, we do have everything in place and we can scale it up even further should it be a pandemic. So it doesn't mean that RSV, we consider it could be a pandemic pathogen, but rather that we use any kind of opportunity to build resilient system that can be scaled up in case of need. Thank you.
Fadela, if I could just add as well, because I think the initiative is very important, because we're all working together, and our member states are working together on a pandemic accord, on the revision of the IHR. We're looking at the systems we need in the future, and there's no question we need to improve how we protect communities. We need to improve our clinical care systems. We need to improve our collaborative surveillance. We need to build better access to countermeasures. We need to improve our coordination and our communication all across the board. They're the attributes of a strong system, but they're generic attributes, they're generic strengths. But if you then face a flu pandemic versus a pandemic of a vector-borne disease or a large-scale epidemic, the interventions are slightly different. So if you have pathogens that mainly affect the lung and you require high levels of respiratory care and oxygen and ventilation, then those pathogens may be very different, but the demand on the healthcare system is very similar. So you can plan. So what I think Sylvie, the initiative that Pret is trying to drive, is to bring those experts together from around the world in these different areas. So we may have specific diseases that are viral or bacterial that could be spread by vectors. Plague is spread by a rodent vector. A yellow fever is spread by a mosquito vector. There are many rodent-borne diseases. There are many mosquito-borne diseases. So if you just lump them together as vector-borne, the interventions are very different. Controlling rodents in a wild environment versus in a domestic environment is a different challenge. So unless you take your generic approach to building systems and you look at the risks and vulnerabilities in each and every country, and you're able to say our particular risks, the things we're vulnerable to here, geographically, from the perspective of our biodiversity, from the perspective of the vulnerability of our community or the types of vectors we have a range of diseases that we need to be ready for. We all need to be ready for global flu, but that varies around the world. And I think making sure that those systems in each and every country are adapted to deal with the threats that they may face, you need to bring that specificity. And I think it's really important in the case of respiratory viruses that we are able to collectively look. We can't prepare for influenza and prepare for the next SARS pandemic separately. We have to prepare for them together, because they're going to have very similar impacts on the same systems, diagnostics, and many other things. So I do think it's an important initiative, and it's something that we're really, really glad to promote. And I must say that looking at the enthusiasm in the room over that 2.5 days and the massive contribution that our partners from all around the world. And again, I think the remarkable thing about that meeting too is it wasn't just scientific partners in the room. There were private sector partners in the room. There were civil society organisations in the room. This wasn't about purely taking a scientific approach to this. This was about taking a broad, multi-sectoral approach to looking at how do we make our systems that we're building ready for the next big respiratory pathogen. So in that sense, I think it's a major step forward.
Thank you. I would like now to invite John Zaracostas from France 24 to ask the next question. John?
Yes, good afternoon. I'd like to follow up on the remarks by Dr. Tedros on malaria. And I was wondering, Dr. Tedros, given you started your career researching malaria, what will be required to make sure that supply meets demand? The projection we're hearing right now is that there will be a shortfall in the new vaccine for malaria. So what are your ideas, sir? And how quickly will there be a plant on the African continent which has most of the burden of this disease?
Thank you, John. Let me give the floor first to Dr. Mary Hamel, who is our team lead on malaria vaccines, and then we will come back to Dr. Tedros if he has something to complement. Dr. Hamel?
Yes, thank you for that question. You are correct that this demand for this vaccine has been unprecedented, with 29 countries already coming forward to Gavi saying that they would like to introduce this vaccine. Already applications are coming in, and the demand far outstrips the supply that's currently available. So WHO and partners have made it a priority to work on increasing supply to meet the demand that's there. There are two ways that we are currently working on this. We work very closely with Gavi and other partners, and actually a roadmap has been laid out that's publicly available that speaks to this directly. But the two major ways are working with the current manufacturer as they proceed with the tech transfer or product transfer of the antigen, RTSS, to Bharat Biotech, a manufacturer in India, which when that product transfer is completed, we expect to see very large increases in volume. The second way is through the development of a second malaria vaccine. And as Dr. Tedros said, there is a second vaccine that's in development. It's in phase 3 trials, and it's currently under review by WHO and our expert advisory groups. So that vaccine, if it is found to be safe, effective, of high quality, then it could go quite a long way in helping to close the supply gap. So I'll hand back to you.
Thank you. Thank you, Dr. Hamel. I believe Dr. O'Brien would like also to say a few words. Dr. O'Brien, you have the floor.
Yeah, the second part of your question was about manufacturing on the continent of Africa. And we are aware, first of all, as you know, from a WHO perspective, very supportive and directly doing work to support the diversification of manufacturing, particularly on the continent of Africa. We know of a number of countries and developers who would be interested in moving forward with malaria vaccine manufacturing. We do engage in discussions with manufacturers about tech transfer or about establishing manufacturing on the continent. And this particular antigen against malaria vaccine from either of the manufacturers, and there are more malaria vaccines in the pipeline, has been certainly identified as one of the ones that would be of particular interest for manufacturers on the continent on the African continent, and we're doing all that we can from our side to support those discussions and to support that possibility of pipelines moving forward with that manufacturing. We're aware of positive discussions that are going on, and we'll await announcements from manufacturers when the time is ready. But I really want to emphasize that as that whole effort on establishing greater diversification of manufacturing, particularly in regions where there are vaccines that are of particular importance in the region, we really see that as a high priority. Thanks.
Thank you, Dr. O'Brien. I would like now to invite Jamie Keaton from Associated Press to ask the next question. Jamie, you have the floor.
Thank you, Ella. Did you say that Dr. Gabawaga was on the call? I don't see her on the stage. Is she there?
She is.
Okay, great. Thanks. My first question really is just a very brief question for Mike. Yesterday, WHO official, can you hear me? Sorry, there's...
Jamie, we cannot hear you.
Can you hear me now?
Yes, please go ahead.
Some noise on the line. Dr. Ryan, could you just, yesterday WHO said that there's something, it was extremely, that there's a problem.
Yeah, there is a problem, Jamie. We cannot hear you. You are cut.
I don't know.
Maybe you can send your question by writing in the chat, and we can try to answer it.
I'll send it to you by WhatsApp.
Thank you. Now I would like to invite another journalist to ask the next question. We have a journalist from Southern Examiner, Nigeria, Aka Nimo Kufre. Can you hear me? Kufre, can you hear me?
I can hear you. Thank you.
Thank you. Please go ahead.
Okay, I don't know if I can throw two songs. I can take two questions at a time, if you permit. First of all, is the idea to journalists, how can we help mitigate against misappropriation of funds by partners to regional governments in the fight against malaria? And then the second one is, if Nigeria is endemic, what is stopping us, WHO, from having vaccines lab and the vaccine production here in Nigeria? What are the challenges that stop that?
Thank you. Maybe Dr. or Kate for the second part, I think is Kate. Did you hear the question?
Yes. So the second part of the second question was about what are the constraints around having vaccine for malaria actually manufactured in Nigeria in particular. Perhaps the question was also more about having manufacturing on the continent. So really, what vaccine manufacturing is about which manufacturer has the means, the capacity, the rights to vaccines that have been developed and have been tested in clinical trials. So there's no specific technical reason why a vaccine can't be manufactured in any country that has the facilities or the capacity, a manufacturer that produces vaccines. With respect to the malaria vaccine, I think probably we should just ground on a couple of things, which is the first malaria vaccine that has now been introduced in 3 countries. And as Dr. Hamill mentioned, there are a much broader number of countries that are now applying for support for the malaria vaccine through the Gavi mechanisms. That's a vaccine that has been in development for over 30 years. It's the first time that there's been a vaccine against a parasite, which is a complex organism and a major scientific challenge to develop a vaccine that would have performance against protecting against severe disease from malaria. So the fact that we have one vaccine already that has taken over 3 decades to actually develop an effective vaccine is really a remarkable achievement. And now we have a second vaccine that is very mature in the pipeline. And as Mary said, we're evaluating that. So I just want to point out that especially for malaria vaccine, this is a very difficult, complex technical area. Not necessarily that making the specific vaccines is so technically complex, but having gotten to this scientific point of establishing what kind of vaccine would actually provide protection has been quite challenging. So, with respect to actually moving production to the continent or developing additional vaccines against malaria, it's really up to the manufacturers about where they'll do tech transfer, who has the capacity to take on the tech transfer, and the partnerships that manufacturers are putting in place. And again, we're very supportive of this happening, very supportive in any way that WHO can be helpful to advance those discussions and to advance actually that development of new vaccines and the manufacturing of certainly the first and perhaps if the second gets fully authorized. We'll see if that can also happen. Thank you.
Thank you. I'm looking at my WhatsApp and the chat. There is no question from Jamie. Yes?
Yeah, thank you. I just wanted to add on the manufacturing. I just returned from South Africa, Cape Town. This was a follow-up visit from last year, same time, to follow up on the mRNA technology hub that we have in Cape Town. The establishment, as you know, of the mRNA hub is to increase the local production capacity of developing or low and middle-income countries. And this is because of the problem we faced during this pandemic, the equity problem, especially with COVID-19 vaccines. And we have seen how the low and middle income countries actually were treated. They were the last to get the vaccines for COVID. And I think addressing that equity gap will be very important if we're going to prepare for the next pandemic. And that's why we have the hub in South Africa, the mRNA hub, and it's already helping 15 countries. And during the meeting last week when I was there, that was on last Thursday, out of the 15 spokes, 14 countries were already there. Countries including Argentina, Brazil, Indonesia, India, Bangladesh, and other countries from Africa like Senegal, Kenya, and from Europe, including Ukraine. And we have seen really a good progress in terms of the vaccine for COVID that was already developed by Afrigen, which is an institution that belongs to South Africa, and all the 15 countries benefiting from that technology. Of course, the mRNA hub is now focusing on COVID vaccines, but it can also, the same technology can also be used for TB, malaria, and other diseases. So that kind of strategic investment is now a priority for WHO, and to, of course, combat many of the major diseases in addition to the COVID-19, which I said, although COVID-19 triggered the issue, this will be used, or local production, building the local production capacity will be at the center of the other diseases also we're combating. Malaria will be treated likewise because, as has been said, I said earlier, especially malaria is a problem in low and middle income countries, and it's not a problem of the high income countries. And investment on developing tools for malaria is really low. We're happy that we have the first vaccine, and that's helping, as Dr. Hamel said. And we have another vaccine in the pipeline. But we will also use new technologies like mRNA and focus on boosting local production and find new tools and produce them in low and middle income countries to address the shortages we have or the equity problems that we face. So I'm really encouraged by what I have seen in Cape Town last week, and we will continue to invest in that. And many countries who are providing support to this initiative have also attended the meeting, especially donors, and they have already committed to continue investing in local production. But one thing that has to be clear is it's the commitment from each individual countries which is very important. Local production is not just to produce vaccines on combat diseases. Local production should be part of the economic development of a country. So commitment from the government is very important. It's not just about local, local production to combat diseases or for health security reasons. It also brings job opportunities. Means it could be a driver of the economy. But then, if that's the case, then many countries now what they're doing with local production is fill and finish. But in order to benefit from the whole value chain and use it as opportunity for job creation, then investment in chemical industries that produce active ingredients will also be important, because the industry can only be more competitive if it increases its share in the value chain of the production, and it cannot be limited to fill and finish alone. So we're discussing with countries to make sure that they have the commitment to take the production of tools for whether it's vaccines or treatment as part of their development agenda, and not only as just producing tools, but as part of their drivers for economic growth. So that's why we call it a strategic investment, and we will continue to help countries to support them in this endeavor. So Fadila, back to you.
Dr. Tedros, I think we will take a last question, in fact, a written question by Jamie Keaton from AP that I will read to you. It's a question for Dr. Gem-Hewege. What has been the impact of journalist reporting about cases of sexual exploitation, abuse, and harassment at WHO? Some old and long-running to accelerate efforts to root out SEH at WHO, like the dismissal announced this week. So, Dr. Gem-Hewege.
Thank you so much. Thank you, Fadela, and thank you, Jamie, for the question. It's actually a great question. I think the first thing I want to say is WHO, and I personally truly appreciate the spotlight that the media are putting on this issue, because we know media attention on an issue really helps us change systems. And this applies for the whole of the UN and for any public institution. So we're really grateful, and we know it was media attention that really alerted us to the tragic and unacceptable situation in the Democratic Republic of Congo. But having said that, the second thing I want to say is that this is one element in a constellation of things. WHO started changing how we work, our structures, our culture, our processes over the last 18 months. And because of the many changes we've made, changing our policy, changing our procedures, having much stronger investigations capacity that is benchmarked, that's fast and fair and efficient, assessing the risk in all our programs, in all the locations where we're working, implementing special measures in health emergencies where you and I both know are really high risk, providing better victim support, and the investment the organization has made in terms of money, in terms of time, and in terms of people are having an effect that is changing our organization. And the evidence I give for this is that currently, for example, just in the last year, our investigation team acted on not just the cases that were highlighted in the media, but have completed 120 investigations into sexual misconduct.